Hey there. My name is Brad Keating. I work with Mountain View Fire Rescue as a fire medic and Boulder County Sheriff's Office as a tactical SWAT medic. And I'm here to talk to you guys today about adapting mass casualty response and triage for the new era. A little bit about me is been a firefighter medic for 16 years, a SWAT medic for 6 of those. I work as a global tox medic instructor, so I teach tox medicine on the side. Uh, I am part of the CTEC triage working group. Uh, I also am a international disaster response team leader for the last 11 years, setting up field hospitals in disaster zones such as Haiti, Japan, Philippines, Nepal, and then working in Israel. And that led me to hold a master's degree in disaster management and humanitarian relief. So let's talk variety and scope of incidents. Let's talk about how the world is changing. You know, an MCI is not simply a large vehicle crash anymore. It's truly an act of terrorism most times. And here's just an example of a few large scale incidents that have occurred globally in the last 5 to 10 years. In Nice, you had a vehicle-borne attack. China had coordinated knife attacks on a train platform. We're all familiar with Paris nightclub shooting. And then you've got some outliers like the Syrian gas attacks, where we're potentially responding to weapons of mass destruction and CBRN type events, and that happened in London too with the chemical attacks. And not to be forgotten, it's something occurring more and more often is using fire as a weapon. So it's taking any one of our traditional MCI methods and adding fire to it as a secondary issue we have to deal with and be prepared for. So why do we need change? Well, we don't really learn from our mistakes. In the pre-hospital field, we tend to do the same things over and over and over again. And we're using outdated and faulty logic, and we don't follow the science. Our triage is done poorly, if at all, and we're not really good at managing our scenes. And we also need to be ready for the increasing size and scope of our incidents. Can you say that you yourself as a practitioner or your agency is prepared for 15, 20, or 100 patients? Because at the end of the day, seconds equal survival. And wherever we can shave time, be it through triage or more rapid extraction from the scene, every second we shave can equal minutes and hours downstream. And that's how we truly save lives. Part of our problem is we use faulty assumptions in our training. We all know advances in civilian trauma care begin in war, just due to the large number of patients and victims we see. We're able to take data from that and correlate it to how we practice medicine in the civilian world. However, that's not always appropriate. It's not a direct one-for-one correlation for numerous reasons. And I think you'll see the problem with battlefield correlation out of this George Washington University study back in 2017 or 18. Now, they looked at 12 mass shooting events in the United States, of which 139 fatalities occurred. They found that wounding patterns, fatal wounds, and survivable wounds differed greatly from the battlefield data that were presented. And they suggested that we can't correlate battlefield data to driver education and treatment of active shooter events anymore, and we need to adapt. So it led to what's called the battlefield fallacy. And if you look on the left, this is our battlefield data. You look at your extremity wounds, your head, chest, and your case fatality rate is only about 10%. So if you took an injury in the battlefield, you only had a 10% chance of dying from that wound. When you look at the civilian mass shooting data, that's nearly 50%. You had a 50-50 shot of surviving an injury in the civilian world. And if you look at the locations of these shots, head and chest compared to head and chest, you're looking at nearly 50% to almost 75%. Extremity wounds go down greatly. But on the left is what we're teaching, that battlefield data. That's what we're using to drive our education in the civilian world. And on the right is what we're truly seeing. So you're asking yourself, why the difference? Well, on the left, this is what soldiers carry, body armor, Kevlar helmets. Engagement distance is 20 to 30 meters. And they often suffer multi-system trauma. They also see lots of IEDs and explosives. And on the right is the civilian world, where there isn't body armor worn regularly. Engagement distance is less than 2 meters. And single system trauma is the #1 killer in these events. Also worth noting, but it's not on this list, is speed at which care is applied. In the military world, when a soldier is wounded, care is applied almost instantly. In the civilian world, we all know those delays can occur, and it's really up to us as the tactical practitioners who are on scene in these hot zones and these really dangerous events to truly try to make as rapid entry as possible and provide point of wounding care as fast as we could. According to the TCCC committee and how we teach our civilian tactical medics, this is what we say the top 3 causes of preventable death and what we can do to save them. Almost 2/3 of it is extremity hemorrhage, a third of it being tension pneumothorax, and then airway obstruction. And this is what we teach. And we teach tourniquet, 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 which is incredibly important. And tourniquets save tons of lives. But in the civilian world, we're not always going to be there fast enough to apply them to have a meaningful outcome with it. So this is what we've been teaching, but this is the reality. This is what that George Washington University study found. It's the top 3 preventable causes of death in mass shooting events. Nearly 90% of it is a pneumohemothorax, 8% airway compromise, and 3% other. And it's got to be discussed that for a pneumohemothorax, as a pre-hospital practitioner, we can't truly fix these. You can always say, yeah, if they have a tension, we can decompress it. But that's not fixing the issue. That's just buying them time. And same with the hemothorax, there's nothing we can do for a hemothorax. What they need is hot lights and cold steel. They need a surgeon. They need rapid extraction and removal to a trauma center. The reality of mass shootings is rapid extraction within 10 minutes of injury would have increased survival rates. They call this, and we've had the golden hour, we're calling this the platinum 10. If we can get there faster as tactical practitioners and get them out of that scene, they have a much, much, much higher survival rate. They found 0 deaths from extremity exsanguination. So if you remember a few slides ago where we talked about the #1 cause of preventable death is extremity hemorrhage, that's just not the case in reality. So once again, tourniquets are extremely important, but for us, by the time we get there, it may be too late. On average, once the shooting starts until it's stopped for whatever reason, either they give up or they're taken down, on average, there's 1 death every 15 seconds once a shooting event occurs. So speed of entry, violence of action, extremely important. And in the traditional way, if we're waiting for law enforcement to clear the scene to say we can come in and treat patients, you're looking at 2 to 3 hours. And that's just not doable. That's going to lead to extremely increased mortality rates. So much so that the mortality rate is going to increase 2 to 4% every minute until they reach surgical care or receive whole blood. And that's really something that's being pushed in the pre-hospital world now, is the possibility of delivering blood at the scene. It's not everywhere. It's hard to do. It's expensive. It's time consuming. But if we can truly bring blood to the scene with us, that's a big benefit. But if not, getting them to a surgeon is the best. And let's look at triage. We don't triage good. Facts are facts. You look at every after-action review, and they always say triage just didn't hold up. Virginia Tech massacre had a 69% miss-triage rate. The Fort Hood shooting had a 70% miss-triage rate. You know, you'd be better off flipping a coin. Why is it so important we get these right? Well, for the obvious, it increases access to appropriate resources, which most often will either be transport from the scene or surgeons, hospital beds. Those are going to be our most important resources. Accurate triage leads to better patient outcomes, and that the frequency and size of our incidents are increasing, and that what we considered an end-all be-all event, such as Columbine, which had only about 40 casualties, is a pretty common occurrence now. And if you look at events like Paris, where you had almost 500 casualties, how many agencies or practitioners can say they're prepared as a medic, as a practitioner, tactical or not, to handle these events? And there's an overall need for change. If you look at the currently utilized big ones globally, being START and SALT, START is very close to SMART if you're using that algorithm. They're very close to each other. you're looking at only about a 55 to 65% overall accuracy rate for appropriate triage. So once again, you're flipping a coin. They found that even if trained and immediately tested using SALT, you're only about a 70% accuracy rate. And if I frequently trained you and provided simulations on triage, we can only expect you to go at 10% better using the current methods. That's not good. And that neither SALT nor START was sensitive or specific in identifying hospital outcomes in MCI patients. What that means is that it's not able to identify the reds. It's also not identifying who's not the reds, so who's the greens. If it can't identify either of those, why are we still using these algorithms? And why are we so bad? Well, it's not all our fault. A lot of these algorithms are built in a laboratory, they're built in a classroom. They're not built to be operational in nature. That statistically on paper, they work great, but when applied in the real world, they're not functional. And one of these reasons is the physiology of fear within responders. These algorithms don't take into account the sympathetic response within us all. The big one being, once you hit about 120, 125 beats per minute on your heart rate, which all of us will be at in these high stress events, you lose your ability to critically think. So that's why we fall back to basic, lizard brain, that basic muscle memory, those kind of things. That's why we train the way we do in the high stress environment. So when the day comes, we just fall back to our training. There's a famous quote that you'll never live up to the moment. You always fall down to your training. And I believe that holds true. So, we lose your critical thinking skills. So right out the bat, any algorithm that requires critical thinking is not going to be helpful. Once you hit about 120, 130, you lose your fine motor skills. So the ability to do complex tasks such as tearing off triage tag forms, those little perforated guys, or any other function is just not going to happen. We fall back on basic muscle memory. And when studied within the United States, they found only 37% of first responders feel appropriately trained in triage. That's a third. Only a third of us feel like we're appropriately trained. And I would argue that number's probably too high. That number's realistically probably lower. They also don't take into account the physiology of fear within our patients. The current algorithms make false assumptions on human behavior. So we're all trained when we pull on scene or you get there and you have a mass casualty event to identify the walking wounded by saying like, hey, if you can hear my voice, come over here or walk to me. The reality is that's not going to occur. Those patients will have fled the scene. Those people who can leave will have left, but that's still how we've been teaching we should be triaging. So we're making false assumptions on human behavior. And we take these and we complicate them with overly complicated algorithms and we expect you to succeed. And it's just not the case. START being the big one. Within the United States, this I would say is the number one algorithm used. It's very close to the SMART algorithm that is used overseas a lot as well. It's way too complicated. Look at this. I have to shrink it to fit on the slide. It's too much. It uses respirations at a rate of 30, which respiratory rate, I would argue, is the number one lied about vital sign in all of our reports. And to truly count respirations, I have to take 30 to 60 seconds and watch you. And we just don't have that kind of time if I've got 300 or 400 patients to triage. It uses numbers. Remember that ability to critically think going out the window? There you go. So using numbers, you can't do it. It's not going to work. It also has cap refill involved in it. Cap refill is a wonderful tool in children. In adults, it's not accurate for numerous reasons, but they have physiologic issues such as diabetes, Raynaud's, just poor distal circulation. It can be cold outside. They can be wearing gloves, or like a lot of these events, they can occur in a poorly lit environment such as a nightclub. So cap refill is not a great indicator for us on adults. And we're going to do just a couple case studies here real quick. San Bernardino shooting had 16 deceased, 24 wounded. So you're looking at 40 casualties. In the after-action review, triage takeaways. High levels of physiologic stress exacerbated by the noise and water from the fire alarm and sprinklers and the smell of the cordite and blood, the screams of the victims. Remember what I said, once your heart rate gets going, you can't really think straight? That's quoted here by the medics. No formal triage system was used by the providers. They relied strictly on the medic's clinical judgment because, and I quote, START triage failed us. And that's a quote directly from the after action review. When the time came to utilize this poorly written algorithm, they could not remember it, and they relied simply on their medics' clinical judgment. And they did a good job. That should be noted. For all these cases I highlight, they did a good job, but we can do better if we provide the right tools. Utoya Island, Norway, 77 deceased, over 150 wounded. Many of these were children or minors of a young age. The triage takeaways from this specifically: no formal triage system was used prior to this incident within Norway. They found an under triage rate of nearly 43%. And because it was mainly performed by physicians flown into the island. And, you know, that's a long delay in triage. And a lot of these physicians might not have had training in how to triage patients, especially in a remote location. It's one thing to triage them when they're walking in the door of your ER, but to triage them in a remote location and not understand the resources necessary to remove them, it caused an under triage rate of 43%. And the last one we're going to chat about real quick, the London Bridge attack in the UK in 2017 had 11 deceased and 48 wounded. 21 of them were critically wounded. Big takeaway from this specifically to triage is many of the walking wounded did in fact have serious injuries. And that falls back to how we were trained in the past is if you can hear my voice or if you can walk, come over here, you're a green. That's not always the case. There still needs to be some sort of a physiologic criteria for how we triage these patients. And that ended up with many of the walking wounded had critical injuries that weren't recognized at the time. So the CDC over a decade ago set out to improve triage. And that's where they developed the Model Uniform Core Criteria, or the MUC criteria. Their big study found no current system is effective. And they also found that, as you can imagine, studies on triage are difficult to perform. Gathering data, biostatistical data, it's very much if you get garbage info in, you're getting garbage info out. And in a mass casualty scene, we're not collecting good data. It's just not possible. They came up with 24 easy to follow suggestions, some of which are very lengthy, but some big takeaway ones were you have to be able to use it in an austere environment, which makes a ton of sense. You need to be able to remember it, also makes a lot of sense. And you shouldn't use numbers or vital signs. Once again, falling back to that, in a high stress environment, you're not able to critically think. So knowing that, using those criteria, I set out to build a new triage system. I pulled from the best systems I could think of globally. Having been lucky enough to go train in Israel for some time back in 2012 on mass casualty response, I looked at the CDC recommendations. I looked at various global studies being published, and I looked at scientific evidence-based approach. And because in EMS and pre-hospital, we need to change when we're confronted with new evidence. So we have known for a long time that our triage algorithms are terrible. We haven't changed them. And overall, I look to simplify it. So how do I do that? Well, I sat down and looked at the science. Found that GCS directly correlated with hospital discharge and trauma. That's great. Problem is, a GCS, or Glasgow Coma Score, is probably the second most lied about vital sign in all of our reports after respiratory rates. Found that, however, following basic commands as a substitute in nearly 30,000 patients was the best overall indicator from trauma. When I say follow basic commands, it's as simple as making eye contact with the patient and having them mimic your hand movements, like squeeze my fingers, squeeze my hand, something very, very simple. That needs to be able to cross language barriers should your patient not speak English. Also be able, in case they can't hear you because they've been in an explosion or in a mass shooting and they just don't have the ability to hear, it needs to be something as simply can conveyed with hand signals. Lack of radial pulse and not following commands had a 92% mortality rate. So if you're building an algorithm for an MCI event, that's a pretty clear black category, or expectant or deceased. Conversely, the presence of a radial pulse and following commands had a 95% survival rate. That's amazing. That's a pretty obvious green category. And it turned out that, unsurprisingly, yellow is the most inaccurate category by EMS. So taking all of this, put it together, simplifying it, I developed the RAMP triage model, rapid assessment of mentation and pulse. And it's very simple. You provide your life-saving interventions as you would with any other patient. You're always going to control that massive hemorrhage, open that airway, possibly decompress the chest if you need to. But the algorithm itself is, does the patient follow commands? Remember that very simple command, yes or no. And then is radial pulse present, yes or no? And if you can follow my cursor, so if they have follow commands, yes, and radial pulse present, yes, remember that's at 95% survival. So that's my green. If they can't do either of those, remember that's my 92% mortality. That's my black. What we're looking for is to identify patients who can do just one of those. Those are my sweet spot. That's the reds. Those are the criticals that need to be removed from the scene most rapidly and extracted to a hospital. And those are the patients who have the highest risk of dying, but still have potentially survivable wounds. And that's the whole point of triage at the end of the day, is to identify the most critical and remove them from the scenes. And that's not to say that these greens don't need hospital transport or don't need surgical interventions. They just don't need them first. And the example I like to give is, let's say we have an IED and we have somebody who has lost a lower leg above the knee. Their leg has been removed, blown off. And there's a tourniquet applied appropriately. And the patient is still following commands and still has a radial pulse. Does that patient need a surgeon? Absolutely. Does that patient need to go before somebody else? Probably not, because as of right this moment, they're triaged as a green, meaning they're stable for right now. Now, they're probably my greenest green, and the second I've got my reds off the scene, that's probably the first one to go. But there are probably more critical patients there, and if there are, that needs to be recognized. So that's the ramp triage algorithm. All right, let's look at a couple of people who've looked at this and compared it to others. So in a start versus ramp scenario of 19 patients, they found time at patient decreased 15 seconds per patient. Accuracy went up by about 30%. And the big one is time until all reds were off the scene. So time until all my critical patients got off scene decreased by a third, by 9 minutes. And remember, bunch of slides ago, 2 to 4% mortality rate increase for every minute they're not at a hospital or at a surgeon. So simply by being faster and decreasing it by a third, we've decreased mortality rates 20 to 40% just by being faster. If we've done nothing else, just by being faster. And this is obviously part of a much bigger discussion on MCIC management, but that's more than this talk can provide. Looking at ramp versus smart. This is out of Australia, data collected by Maddie Pepper. Time to triage, cut in half. Accuracy, almost 100%. Those are great numbers. Almost 100% accuracy using ramp triage. So the fact that they can be faster and more accurate is incredibly important. And I know we're kind of limited for time on this discussion. So that's all I have for you all today. Feel free to reach out, contact me. This is my work email address. I'm happy to discuss things further with you. I'm happy. There's actually a much of a longer version of this talk that goes into scene management. I'm happy to give that to you as well, if anybody'd like to hear that. Thank you for listening, and I appreciate all your time.